everybody, and welcome to the Neurocritical Care Society podcast. This is our hot topic series, and today we have a very hot topic indeed. I'm here with some members of the working group from the Neurocritical Care Society Neuroprognostication Guidelines. These guidelines have been ongoing. They are being released in real time. We're really excited to see these come through. I'm your host, Nick Morris from the University of Maryland Shock Trauma, and maybe we'll just go around and introduce ourselves. So, Katja, would you begin for us?
Sure. My name is Katja Wartenberg. I'm a neurointensivist. I work at the University of Leipzig in Germany, and I'm also the secretary for the German Neurocritical Care and Neuroemergency Medicine Society, and one of the chairs of the Neuroprognostication Guidelines.
Great. Susanna.
Hi, everyone. My name is Susanna Mioschegel. I'm a professor of neurocritical care at Johns Hopkins University. And together with Katja, I'm the co-chair of this neuroprognostication guideline representing the Neurocritical Care Society.
All right, and Krishna.
Hey there, I'm Krishna Rajaji. I'm a professor of neurology and neurosurgery at the University of Michigan. My role in these neuroprognostication guidelines was grade methodologist, and I'm the former chair of the guidelines committee at the Neurocritical Care Society.
Great. Well, thank you all so much for taking time out of your day. I think a lot of people are very excited about these guidelines because we've really never had guidelines like this in place. Maybe you can start by talking a little bit about the motivation to develop these guidelines and how you all got started. And Katja, would you mind taking that one?
Sure. Back in 2018, we had the second joint meeting of the German and the American Neurocritical Care Societies in Würzburg. And at that time, we had a series of sessions about prognostication in certain critical care diseases, which went very well, was very well received, and ended up in a paper called The Gap Analysis in Neuroprognostication for 8 different diseases. And while doing the gap analysis, we already identified many flaws and failures regarding neuroprognostication and the available or not available evidence at that time. And we decided that this might be a good base to start the neuroprognostication guideline series for the 8 diseases that we had already considered.
Excellent. And how did the group go about picking those 8 diseases?
Well, we basically looked at the frequency of the neurocritical care diseases in our own ICUs, and for sure the cerebrovascular diseases and trauma are the most prevalent disease states that we see here in our ICU beds, and those of course we picked, and then we thought about other diseases that we might also see more frequencies than others, and came up with status epilepticus, spinal cord injury, and we wanted to pick at least one neuromuscular disease, and so we ended up with Guillain-Barré syndrome. Why we picked that over myasthenia gravis, I don't know, probably because there was some more evidence or more interest in that disease at that time. We certainly did not cover everything, but it's also impossible because these 8 diseases are already like 8 guidelines instead of 1, and was a tremendous amount of work that we had to cover, and therefore we had to limit the amount of diseases in the guidelines.
No, it's a gigantic undertaking, and I congratulate you all. So I think so far, by my count, we have neuroprognostication guidelines for intracerebral hemorrhage that have been published, for Guillain-Barré syndrome, for the comatose patient after cardiac arrest, and then most recently for moderate and severe TBI. So already just a tremendous amount of work has been done, and there are more to come. Is that right? So what are the other diseases we have coming forward? I think you mentioned spinal cord.
Spinal cord injury is also published already.
I missed it.
And yeah, the other diseases still in the pipeline are status epilepticus, which will probably come out next, and subarachnoid hemorrhage and acute ischemic stroke are still in the making.
Great. And Krishna, can you walk us through a little bit about how the working group developed these guidelines and the grade methodology?
Sure, Nick. So I think just to take a quick step back, I think it's useful to give this a little bit of historic perspective in terms of methodology. There have been limited neuroprognostication guidelines in the past, right? I mean, most of them are focused on cardiac arrest. And if you look at the methodology that they used, they didn't truly use grade methodology in its entirety. So some of those, I think the past neuroprognostication guidelines, will use the spirit of the grade guidelines, but they didn't really use all of the required elements of the grade guidelines. There's a huge difference between the two. Most of the past neuroprognostication guidelines that you will see either effectively or sort of openly used expert consensus. They're really consensus guidelines. So when you ask yourself, why is this in some ways different from other guidelines or past guidelines? It's the methodology. It's that, this is really the only guidelines that is truly used all of the specific and required elements of grade methodology. And I'm happy to answer any questions about how that's a plus or a minus, but that's the difference. I mean, it's the methodology is fundamentally different. I mean, why use grade methodology? Fundamentally, the Neurocritical Care Society, similar to other societies such as SCCM, have committed, the societies have committed themselves to grade methodology. Why is that an important thing for neuroprognostication? Because I think that the rigor matters. I think we've seen that in the past. If you look at just neuroprognostication after cardiac arrest alone, I think that all of the guidelines that preceded us are extremely valuable. I mean, clinically extremely impactful. But some of those recommendations have not necessarily stood the test of time. Just to use an example, the recommendation that that the motor response after cardiac arrest is a highly reliable predictor of outcome. We believe that completely at the time. But it turns out that that's 30% false positive rate, up to a 30% false positive rate, has extremely real clinical impact on a day-to-day basis. Anyone who's run a neuroprognostication service and has used that predictor to tell patients that their families are not going to do well knows that has huge clinical impact. So I think that the starting off, I think the group, the society felt that methodological rigor was important. And grade methodology is sort of the standardized way to ensure methodological rigor and guidelines.
Great. And can you talk a little bit about what evidence or criteria were used to determine the recommendations? Because I think this is also a bit of a difference, and I think it's really important for the listeners to understand.
Sure. So we really stuck to grade methodology and all of the required elements of grade methodology. There's a couple of misconceptions about grade methodology. One of those is that the quality of the evidence kind of puts you in a straitjacket, and you can only provide recommendations if there's high quality of evidence. In fact, grade's kind of the opposite, in that it really allows you. That's another big part of the reason that the Neurocritical Care Society originally went with grade was that you actually have the freedom to and almost a requirement to provide clinically meaningful recommendations, even when the quality of evidence is low or very low. So in fact, grade requires you to consider 4 criteria when you provide a recommendation to back up your recommendation, and we did. I mean, that had a big role in the recommendations that we put out there. So there's a quality of evidence, which is huge. Then there's the balance of pros and cons, desirable and undesirable consequences. There's values and preferences and resource use. So if you look at those required elements and in the way that they impacted the neuroprognostication guidelines, a huge element was pros and cons, which is to say, if we were to provide this recommendation to use this prediction model or predictor systematically to counsel families that their loved one is not going to do well, for example, what's the pro? The pro is that you're providing information, you're providing them some data. People want that. The con is that if the consequence of that, the family withdraws care on someone who would otherwise have done well. That's a devastating consequence. That is the worst case scenario. And that criterion, which is not strictly a quality of evidence criterion, but it is an important grade criterion, was, I think, weighed heavily on us when we made a lot of these recommendations.
Yeah, Susanna, I imagine that this weighing of the pros and cons, as I see it, and I'm excited to get your thoughts on this, it really goes a long way towards fighting against these self-fulfilling prophecies that we see in neuroprognostication. Can you talk a little bit more about that?
Yeah, so, as Krishna already said, many of the guidelines that we see out there, both from our own society and that of others, sometimes uses a different methodology, which is often very much expert opinion based. And so it almost feels like as you read them, it's a self-perpetuating continuation of these opinions. of expert providers that then gets passed on to generation and generation of clinicians. And I think what we tried to do here is really stick with a validated methodology that's, highly recognized in the field of guidelines. And, the downside is that we discovered and described that the literature really isn't as robust as everybody thought it might be. And so, I will say it outright, we've been criticized as an author group that these guidelines are, quote, not very helpful because we cannot recommend a lot of things as highly reliable or even moderately reliable, and really outlined what the literature is. And we always counter argue then, well, it is what it is, and the literature is what it is. And I think it's really important to show that the recommendations by others that are maybe opinion-based aren't as robust and as rigorously assessed as what we tried to do here with this guideline. And so we kind of open up, that perception that for many years, this is how it is, and which then leads to self-fulfilling prophecies. And I think this is maybe an eye-opening experience, not just for the authors, hopefully for the readers, to see that the literature isn't as robust as everybody thought based on expert opinion, and that there is a lot of need for rigorous research still.
Great. Maybe we can dig into that a little bit with an example. So when I think of moderate to severe TBI, right away I jump to GCS as something that is in almost every multivariable model that comes out of any single center research seems to be associated with outcome, and yet your group did not find GCS to be a reliable prognostic variable for functional outcome at 6 months or beyond. So what's going on there? Why is there this discordance between what we kind of see as readers of the literature and what the working group found?
Yeah, so one thing that grade also requires is a PCOT question, right? So it's this question as to, does, in our case here, X variable predict outcome? And then we as an author group thought it was very important to emphasize X variable alone, right? So when you read the recommendations, we clearly say that GCS or motor GCS for TBI shouldn't be used alone, and every other variable. And so when you use maybe motor GCS in conjunction with other things, such as when you look at our models that we evaluated, we did find that several models, when you combine certain variables, might be moderately reliable. And we can speak a little bit about what that really means and how we define moderately reliable. But alone, the motor GCS, the literature just wasn't there and wasn't as robust to support that. Now, when you look at pupillary reactivity as a comparison, we did find that as long as you rule out that there isn't another reason for fixed and dilated pupils on both sides, we could recommend that as moderate reliable, I believe, for a poor functional outcome at 6 months or beyond. So it is really the wording of the PCOTS question that matters. And these guidelines then also go into the literature and describe exactly as to why we graded it one way or another. I think the biggest problem we all encountered is when we use these specific kind of almost like questionnaires to assess the reliability. And the issue of studies not reporting on rates of withdrawal of life-sustaining therapies, or whether physicians who treated the patients were aware of certain things. So many of the studies, the majority of our studies, were tainted and were downgraded because of the presence of self-fulfilling prophecies. And I think that was a major limiting factor.
And Krishna, it looks like you have some more to add to that.
No, just to sort of add on to what Susanna said, this idea that anyone would use GCS alone to prognosticate. What we hear a lot of is from intensivists, well, nobody would do that. I wouldn't do that. Like, I would never use GCS alone to prognosticate. I feel like we're a little bit cocooned in an ivory tower sometimes when we say that, when we say, well, nobody would use GCS alone to prognosticate. A lot of people do that. If any of us who I mean, obviously we all care for our own trauma patients, but if you ever go out there and, help someone else care for a trauma patient, you know that to be true. You know that someone's going to come to you and say, hey, this person came into the GCS at 3. I mean, obviously his prognosis is poor. Why are we doing anything? Can you please tell the family that? Or I'm not even going to put it on an ICP monitor. I feel like as neurointensivists, sometimes we're not fully exposed to what people actually do out there. And I think that people really do need to hear that, not using the GCS alone or age alone to prognosticate a poor outcome, really we shouldn't be.
I agree. That's so important. And the age one, I think, comes up again and again for us. We hear, oh, no, it's patients such and such age. And so they're just not going to do well. And we just know that's not true, right? And this ivory tower prognostication, I think, is a really good point. Susanna, you mentioned some limitations to the research. So one, failure to report on withdrawal of life-sustaining therapies. What are some of the other, I imagine at this point, you all have reviewed so much of this literature. What are some of the other major failings of the research that's kept us from moving forward with higher reliability recommendations?
So there's so many, Nick. I'm just going to pick a few for reasons of time. But for example, on prediction models, every model that we found reported on area under the curve. So the so-called C statistic, or, in statistical terms, the discrimination. How well does this model discriminate between sick versus not sick? But what's really more important in real life, and when you're trying to predict a patient's outcome at the bedside, is calibration. So how well is this model calibrated? And we were surprised how few papers actually, in addition to the area under the curve, report calibration. And there's even been papers written about this. So the group around Hester Lingsma has done this in TBI. They've looked at all of the, validation studies of the impact model and saw that only maybe half of the papers report calibration, although people who are experts in prediction modeling, like Hester Lingsma, really emphasize how important calibration really is. So, we had to downgrade many of these models because calibration was never mentioned. Often these were, single center studies, for example. Very few were multi-center. And then there's the issue of internal versus external validation. So just for models alone, there were kind of many downgrades that we had to do.
And Susanna, for those listeners who aren't familiar with the concept of calibration, can you just briefly define that for them?
Yeah, so it's essentially how well does this model predict the actual outcome versus the predicted outcome. So kind of the observed versus predicted. And calibration varies based on your population. So for example, you might have a really well-calibrated model that was derived in, in the impact cohort, or in, let's say, a Dutch cohort, but then you go and try to apply it to the shock trauma cohort at Maryland or some other hospital. It may not be as well calibrated. Ideally, you want to calibrate every model in your own population. That's nearly impossible, so you rely on other calibrations. But that's really what calibration does.
Great, thanks for that. You brought up the impact score and in moderate severe TBI recommendations. We talk about the crash score as well. Let's talk, maybe if we can, a little bit about clinical prediction models. And this has always been, I think, a hot topic in neurocritical care, the development of clinical prediction models and how we use those models to speak to individual patients. And you'll hear this given on different models, that these models are not meant to prognosticate in individual patients, whereas some models, it seems like we can use for individual patient recommendations. So help us, as people who are clinicians talking to families in a family meeting room, how should we use these models, and when is it appropriate to use them to speak to families?
Yeah, I can try to answer that. So in general, you want to be very careful about applying prediction models to an individual patient. And that's just because these models were developed in thousands of patients of some population, and they will predict, in a population like that, an individual patient may have some other things going on with them or some other variables that are not part of the model, but that may matter. Things like frailty, for example, is a hot new one, or even social determinants of health or pre-existing cognitive status, things that don't always make it into these models. And, those of us who have created their own models, we've always struggled with the outliers, right? So my model looks beautiful. You do a scatter plot and, you have a nice linear thing, but then there's these outliers and you're trying to explain them. And for me, when I, created my own models, it was always very kind of unsettling trying to explain what's wrong with this outlier. And then I think, well, if I'm the physician predicting an outcome and it's that patient, then my model won't apply. So I think we have to be careful. I think one thing I want to point out in this guideline that we're very proud of, and thank you to Krishna for, making us do this, is we also suggest language to use as physicians when counseling families. And so we, for example, define our predictors or models as reliable or moderately reliable, and then with that, provide language that might be used. So for example, if you have a reliable model, which, by the way, I think very few, I think if any, I don't think we had any highly reliable models in any of us. But in that case, you could have used language for the likelihood of outcome as very likely, or you want to always mention uncertainty, and you could say uncertainty is present but low, and this is for reliable predictors or models. For example, we had several that were moderate or reliable, and so we provide language to the physician that should be used when counseling families, such as the likelihood of outcome is likely, but it kind of, you're supposed to leave open that chance of uncertainty, and that there's substantial uncertainty about the outcome. And so what we are doing is trying to be helpful. Yes, you may use it in a certain way when counseling families, with the caveat of using specific language to make it very clear that there is really no model out there that predicts the future with certainty.
Great. Katja, let's talk a little bit about the intracerebral hemorrhage prognostication guideline, if you wouldn't mind. In this case, we have a couple different clinical prediction models, and none of them were found to be reliable at all. In fact, in that guideline as a whole, I think maybe one of the criticisms your group got was that almost nothing is reliable. So where does that put us when we're sitting down with a family if we have nothing of any reliability? How do we broach the topic with families when we're talking about prognostication?
Well, first of all, what applies most is what Susanna already mentioned, the principle of uncertainty. For the ICH models, you can only recommend to the clinician to use them as a communication tool of the severity of the disease, because this is the way they were designed. If you look at them closely, and I think that applies to almost all models that we looked at in all disease states, they are basically composed out of admission variables: age, GCS on admission. So now it may happen that the patient with ICH has a GCS of 3 because he has also an intraventricular hemorrhage and he needs an intraventricular drain. And once the intraventricular drain is put and the week has passed, maybe the patient wakes up and has a GCS of 11. We don't know that on admission. So we can use the model and say, okay, it's a severe bleed. We may want to give him some time, a week of full life support, and then we sit together and see how the way the road has taken us, what else happened to the patient in the meantime, how the social support is at home, how the patient was before, what are his circumstances, what are his personal wishes. All these things have to be taken into account, and no single model in history and in the literature has ever looked at all these things, because it's simply impossible. So the entire progress in the hospitals, hospital complications, they don't matter. And when counseling a family, all these variables have to be taken into account.
Great. Krishna, when I think about the cardiac arrest guideline, one thing that I think some of us have struggled with is the algorithm that's given. as you mentioned, and I think this is a very important point, that the group looked at how each variable predicts outcome in and of itself, sort of out of context of other variables. But where does that put us when we have perhaps multiple reliable predictors or multiple moderately reliable predictors? Does that, when you sit down with families, does that change the way you speak to them, or do you still use the same language that's sort of recommended in I think the figure that you give?
So, I think this is a useful opportunity to point readers to the actual full text of the guidelines and that algorithm that you refer to, Nick. I think we want people to look at it and to sort of read the evidence behind it. So the way that we had it was that if you have multiple moderately reliable predictors, and in the specifically for cardiac arrest, it's an imaging predictor, EEG predictor, for example. If you have multiple of those predictors, then the language we suggest is that the outcome, in this case, a poor outcome, is likely, but that there is significant uncertainty or substantial uncertainty involved in the prediction. That's the language we suggest. With reliable predictors, the language that we suggest is that the outcome is very likely, but that you still need to acknowledge that there's always uncertainty to prognostication. I think to your question of, well, what if there's two reliable predictors? What if there's 3 or 4 moderately reliable predictors? We're not going to be prescriptive in saying that you've got to use exactly these words. I mean, I think every clinician needs to use judgment and common sense in moderating the language that they use. Essentially what you have is, so let's say that you've got an EEG with suppression, you've got a CT with anoxic injury, and you've got sluggish pupils or something along those lines. Well, then you're telling yourself, I think this is worse than just one moderately reliable predictor, so I'm going to be a little bit more strong in my communication. And you'd probably be justified in being so. We're not being prescriptive and saying you can't do it. It's just that essentially what that becomes is an unvalidated clinical prediction model, right? Clinical prediction models have multiple factors that you put together. Now we've got these 3 or 4 predictors that you're putting together, and I think that it's bad, but it's never that combination of EEG, CT, and sluggish pupils may not have actually been validated per se. So that restricts the language we can use and the recommendations we can use in a guideline. But that's never to say that we ask clinicians to put aside common sense and that we be extremely prescriptive in the language that they use. So, I mean, I think to some extent we try to provide structure and try to provide suggested language based on the findings that you have, based on that algorithm, but it can't possibly cover every situation. And we encourage clinicians to use their best judgment in sort of individual situations.
Great. I think that's very helpful. Susanna, you've thought a lot about how our language affects the way that patients or their surrogates take in this information and then use it to make decisions. What do we know about what families think when we say things like, this is very likely versus likely, or there is significant uncertainty, or there is some uncertainty? Are these significant differences as understood by families, or is this just more for our benefit?
Yeah, so I think I'm not sure that the uncertainty part has been studied. You're bringing up a good idea for future study. What we do know from what some folks have done in the general critical care literature is that when they use absolute language, such as there is no hope, or he will never wake up, or there is 0 chance of X, Y, and Z, unless someone is actually been declared brain dead, right? But if someone's still, ventilated critically ill, and then the physician comes in and says, there's no hope, that's it, nil chance of anything, that actually creates optimistic bias in surrogates. And so while, maybe the intent by the physician is such to create no false hope, and in a way that's a good thing, and it's what families want, we have to be very careful in how we say that to families. And so things like it's highly unlikely is probably a better way to term that in such a case. And I think we all have to look at our own biases. Sometimes I cringe, and this has happened to me in the past, where a physician feels very strongly about a poor outcome, and then the family continues care and things turn the other way. And so we all as physicians have to be humble that we really don't know. Again, other than in a case of truly declared brain dead or near brain death. And so, families, what we know is want you to be very open and acknowledge the fact that there's uncertainty. They know that doctors can't know it all. And in fact, when doctors go in and pretend they know it all, it actually creates more of this skepticism and distrust in families. And so I think if we use more humble language, it does not confuse families. It actually makes it more clear that we really don't know. And then we really should have conversations about values and preferences in the family, just as we always hear in the palliative care literature, but unfortunately in neurocritical care, we still don't do it all the time. And really get at, well, does this align with the family? And, I think we all, as we read more and more of these studies about long-term outcomes, I'm thinking about a recent study, 12-month outcomes in the ICH population or in TBI. People are surprised that if you give folks time, that there might actually be quite a few people that turn the corner and have no disability or very little disability. And so I think the more we study this and the more we actually allow people to live, the more surprised we are. It doesn't mean that everyone will do well, but which one will and which one won't, I think is getting maybe even harder to differentiate.
That's great, and such a fascinating thing that sometimes by being too definitive, we have the opposite effect on families, that we are giving them optimistic bias.
That's exactly right. Yeah.
Katja, having gone through all this literature and working on all of these manuscripts, are you seeing some general themes emerge that you think are important for all the listeners to hear?
Certainly. The most general thing that I can say that there was little evidence for evidence in all the analysis, and at least little evidence to recommend a predictor or a prediction model as reliable. And why is that? Well, because most studies that we used were retrospective or were taken from prospective trial cohorts, which were not designed to look at outcome and prognostication. So this is basically all a second analysis. The next is that usually only admission variables were considered. Rarely anything like Susanne mentioned before, the pre-state, for example, cognitive state, or the pre-hospital Rankin score as a functional state. Most of the time, only functional outcome and mortality was considered, where, for example, it might be so much more important for a patient and family how the cognitive outcome is, how the emotional outcome is, what the rate of depression is to be expected, the level of anxiety, because that contributes much more to the functional state than we can imagine, more than the ability to walk for some people. Then the next thing is that the entire hospital course did not get acknowledged in those analyses, and maybe for future research, those populations should definitely be studied in a prospective trial where you have the ability to exclude patients with advanced directives and limited life support, for example, during the first week. You should look at different parameters at different time points and consider those more soft outcomes, which are harder to study because you need speaking patients or a heavily involved family member. There's also such thing as patient-centered outcomes, which become very popular, which have to be looked at, or surrogate opinions, surrogate outcomes. And these will probably form after all the guidelines will be published, and we shall see how the outcomes research is changing, hopefully.
Susanna or Krishna, any other thoughts on how we move forward to have more reliable predictive models?
Yeah, so I think my big hope is obviously, for example, in TBI, centered TBI, track TBI, it's really been designed to do exactly that, right? Not to just do a GOSE, but to do neuropsych outcomes and all these other things. So I think a lot will come out of that, has already come out of and will. I'm also excited to see papers from other countries that have equivalent levels of medical care. I'm giving you examples such as Brazil or South Korea, but where withdrawal of life-sustaining therapies just doesn't happen for various reasons. It's either not allowed by law. I believe that's the case in South Korea, from what I know, or in Brazil, where it's just not done out of just social reasons. And there are ongoing studies in those cohorts trying to get around the self-fulfilling prophecy in early withdrawal of life-sustaining therapies. And so I'm very excited to see what comes out of those. I mean, I can think of a cardiac arrest study published in Critical Care Medicine from South Korea, where, you know, the time to awakening was studied. And so that we learned that even after over 50 days after cardiac arrest, people may still wake up. So I think these are those studies that may hopefully give us more information and answers. I think they're still very difficult to do in, you know, the US or even European countries, where this notion of my loved one wouldn't want to be on a ventilator for a prolonged period of time is still very prevalent, and it will be difficult to not have life-sustaining therapies.
Krishna? Krishna, you're on mute.
Sorry about that. So, just to quickly add to that, I think I just again want to direct the listeners to the manuscripts where we actually provide more granular recommendations for future research. There are smaller things. If you're a researcher doing a prognostication study, observational study in the United States, there are still things that you can do to make these studies of higher quality. One is to make sure that this is the right outcome at the right time for your disease. Not assessing the outcome at the right time was a big factor in some of our disease states. Predictors, make sure that you use a standardized sort of definition of your predictor. If it's status epilepticus, make sure you use a standardized definition of status epilepticus, for example, and that if your self-fulfilling prophecy, Susanna mentioned, we don't have the same conditions as South Korea, or even Japan, but you can try to have an institutional sort of guidelines to not withdraw life support for at least, say, 72 hours for cardiac arrest, just as an example. You can make sure that the predictor that you're studying is not systematically incorporated into counseling of families. That's a huge problem. And if possible, if it's not a part of standard clinical care, the biomarker, for example, blind the clinicians to the predictor entirely.
Susanna.
Yeah, I wanted to add, for those folks who are or want to undertake prediction studies, is to take a look at the risk of bias assessment tools that GRADE uses. So for individual variables, that's QUIPS, stands for Quality and Prognosis Studies, or for models called PROBAS, Prediction Model Risk of Bias Assessment Tool. Those are very detailed tools, what we used to extract data and assess each study's risk of bias. But I found them eye-opening as to what would be a study that has a very low risk of bias. And so for anyone who wants to do such research, take a look at those tools and then design your study accordingly.
Great. And as we wrap up, and this has been a fantastic session, so thanks so much for joining us again. I'm wondering, as people leading this charge, how has this work informed your clinical practice? Katya, have you changed the way that you approach the family meetings or even your clinical care based on this monumental task of going through all of this literature?
Well, I certainly went into each family discussion more informed than I was before. I've also included the principle of uncertainty, which I learned from Susanna, actually. And I've never used scores and prediction models in a family discussion. I presented likelihoods which are now more underlined by everything we have experienced in the process of these guidelines. So yes, it has a little bit influenced my practice, although as we said before, we're in the ivory tower. We had the knowledge before, and we never allowed the principle of self-fulfilling processes to influence our daily practice.
Susanna, slightly different question for you, because you've been involved in building some of these clinical prediction models, particularly one I enjoy is in penetrating brain injury. How has this work informed your goals in perhaps future research?
Well, you know that I'm very interested in shared decision making. I think it has really, strongly emphasized even more the need for this. And I think now maybe I have something to show my colleagues who tend to be very certain in these family meetings to say, we probably shouldn't be as certain and we should use a specific language. And now at least I have something to back me up, to be honest. I mean, personally, I think it just is to show that we just can't be overly certain and that we just need to approach each patient as to trying to get to know them a little bit as to what they would or would not like. And the more I read about this disability paradox, to be honest, that goes into, well, once people are disabled, they perceive it very differently than what they perceive it as a healthy, able person. And so I try to bring that into the family meeting as well a little bit.
And Krishna, any last thoughts for us?
So yeah, just really quickly, I just want to direct readers or listeners to the fact that although that these guidelines found a lot of predictors to not be useful, and some of these guidelines we do direct readers, listeners of this podcast, to models and predictors that are relatively more reliable than others, which are preferable to just arbitrary sort of prognostication. So there's the algorithm with cardiac arrest. For Guillain-Barré syndrome, there's the Erasmus prediction models, which that affected my practice. I actually use those pretty routinely to help counsel GBS patients now. There's the Dutch prediction model in traumatic spinal cord injury. There's the impact and crash with traumatic brain injury. So it wasn't all we can't recommend this, don't use this, don't use that. There actually are predictors that we sort of sifted through and said, this really is better than completely nothing at all or being arbitrary decision making. There's also the good practice statements, which I think are particularly useful for trainees, for folks who are not as experienced with neurocritical care management. I think they're going to be surprisingly useful for folks. So I do think there are substantial positive recommendations in these guidelines that I want to direct the listeners of this podcast to.
Well, that's a really good point, and let's end on that. I want to thank you all so much, not just for coming on the podcast, but for all of your hard work on developing these guidelines, and really thank the entire working group, because I know it takes more than 3 people to develop 8 manuscripts in probably thousands and thousands of publications that are behind those. So thanks to all of those who have been part of the Neuroprognostication Guideline Working Group. And thanks to our listeners for joining the Neurocritical Care Society podcast. I'm your host, Nick Morris. The podcast is available on the Neurocritical Care website or wherever you get your podcasts, and continuing medical education credits are available for select episodes. Thanks so much and have a great day.